In this talk, we'll take a look at the specific fracture types commonly affecting the long bones and discuss, using what we've learned, how we might approach repairing them if indeed this is possible. Again, I'll stress that I'm going to concentrate on fracture types and methods of repair that can be employed relatively easily and with minimal cost for the patient population that we are dealing with. I'm going to start at the shoulder joint, work my way down to the distal radius, and then move on to the hip joint and work down to the distal tibia. Traumatic shoulder luxation. Although not a fracture, I thought I'd mention this briefly. Traumatic shoulder luxation is uncommon and usually follows a road traffic accident or other major trauma. The humeral head can luxate either medially or laterally, and craniocaudal x-rays help with the correct diagnosis, although by palpating the greater tubercle of the humerus and acromion and comparing it with the other side, you will get a good idea. X-rays still need to be taken though to rule out concurrent fractures. In both cases, the elbow is usually flexed and held into the body. Generally speaking, with medial luxations, the lower limb is held away from the body, whilst with lateral luxations, the lower limb is held into the body. If there are no associated fractures, then reduce the joint under general anaesthesia and place the elbow in a sling. We use a Velpo sling for medial luxation because it pushes the humeral head in a lateral direction, and a non-weight-bearing sling such as a carpal flexion sling for lateral luxations. We keep the slings in place for a couple of weeks with a further 4 to 6 weeks of restricted lead exercise after this to allow periarticular fibrosis to return the joint to stability. Repeat luxations will require surgery. This slide shows two views of a lateral shoulder luxation, and you can see from the medial-lateral view here that the joint looks almost normal. And it's not until we look at the craniocaudal view over here that we can see the full picture. The humeral head here is luxated laterally from the glenoid cavity of the scapula. This would be reduced and a non-weight-bearing sling used for a couple of weeks. Traumatic elbow luxation. Again, this is worth a mention while we're talking about traumatic injuries, and again it's an uncommon injury, usually following a road traffic accident. Elbows almost always luxate laterally, that is, the radial head and ulna move in a lateral direction, and this is on account of the fact that the medial condyle of the humerus is significantly bigger and more robust than the lateral condyle. X-rays must be taken to rule out associated fractures before attempting a closed reduction. And to replace a lateral elbow luxation under general anaesthesia, we flex the elbow fully and pronate or internally rotate the lower limb, and we try and get the anconeus to engage with the olecranon fossa, and then slowly extend the elbow while pushing medially on the radial head. X-rays must be taken to confirm relocation. If successful, then again we support the joint with a full limb or body lateral splint such as a spica splint for 2 weeks, and then restricted lead exercise for 4 to 6 weeks. Failure to be able to relocate the elbow or repeated luxations will require surgery. With both shoulder and elbow luxations, there will be significant disruption of collateral ligaments and other soft tissue supporting structures of the joint. Many of these cases may present to you as chronic injuries that happened many days or even weeks previously. In these cases, the chances of achieving a successful closed reduction of the luxation are extremely limited. These injuries have the most success with closed reduction if performed as soon after the traumatic event as possible. This slide shows a traumatic elbow luxation both before reduction, where we can see this dramatically increased joint space, and after reduction. Fractures of the scapula. Scapular fractures may be accompanied by thoracic wall injuries due to their associated anatomy, and so thoracic trauma, which could be life-threatening, must be ruled out before focusing on the scapula. The scapula is surrounded on all sides with a good covering of muscle, and so it has a great healing potential. And this is good news for us since it's a very thin bone which is not good for putting implants in, so many scapular fractures are treated conservatively with rest and analgesics. The scapular fractures that will require surgery are those that directly involve the joint surface, overriding fractures of the scapular body where there's marked displacement, fractures of the neck of the scapula, and avulsion fractures of the supraglenoid tuberosity at the point of the origin of the biceps tendon, and also avulsion fractures of the acromion. Fractures of the joint surface require internal fixation to accurately reconstruct the glenoid cavity, so we won't be covering this. Overriding scapular body fractures can be approached by placing orthopedic wire sutures from lateral to medial through the body of the scapula near the base of the spine where the bone is at its thickest. These can then be augmented by a wire figure-of-8 suture in the scapular spine. Scapular neck fractures can be treated using crossed arthrodesis wires. And supraglenoid tubercle avulsion fractures are amenable to fixation using the tension band techniques that we've been discussing. Beware here though, don't confuse the normal growth plate appearance of the supraglenoid tubercle of the scapula in a puppy under 5 months of age with a fracture. If in any doubt, X-ray the other shoulder for comparison. One other rare fracture of the scapula is another avulsion fracture, this time of the acromion at the distal end of the scapular spine. The pull of the acromial head of the deltoid causes the bony fragment to separate. This can be repaired using a tension band technique, but if the acromion fragment is too small, then a simple figure-of-8 orthopedic wire suture may do. When operating in the area of the scapular neck, be very aware of the suprascapular nerve. It's the only major nerve in this area and it innervates the supraspinatus and infraspinatus muscles. It's found in the lateral aspect of the scapular neck. This is an avulsion fracture of the supraglenoid tuberosity at the attachment of the biceps tendon. Here it has been repaired with 2 screws since this was a large breed dog and the fragment was big enough to do this. With the techniques that we've discussed today, we would approach this using 2 arthrodesis wires and a figure-of-8 tension band orthopedic wire to counteract the pull of the biceps muscle. The arthrodesis wires would be placed in the same position as the screws, and I've illustrated the position of the orthopedic wire in red. This is a complete fracture through the neck of the scapula. It's easier to see here on the craniocaudal views. It's a very unstable fracture which will require to be stabilised. It's going to be very difficult for us to reduce this and repair using 2 crossed arthrodesis wires, so amputation may end up being the best option here. In this particular case, it was repaired using a plate and screws to provide the stability required. Scapular body and spine fractures can sometimes be difficult to see on X-ray, so study the pictures well and take a contralateral view if there is any doubt. This animal here has a minimally displaced incomplete fracture of the base of the scapular spine on the left side, and you can see the faint fracture line running up here. This is a case that would probably respond well simply to conservative treatment. Physial fractures of the humerus. In young animals you may see growth plate fractures where the greater tubercle and humeral head separate from the proximal humerus together, and these are Salter type 1 or Salter type 2 fractures. Repair of these involves placing 2 arthrodesis wires from proximal to distal and a figure-of-8 tension band wire. In very young dogs, we would perhaps just place 2 parallel arthrodesis wires without the figure-of-8 tension band in the hope of retaining some growth plate activity. In older dogs with limited remaining growth, we would want a more secure fixation and we would use combined arthrodesis wires with a figure-of-8 tension band to counteract the pull of the supraspinatus muscle on the greater tubercle. The approach is via a craniolateral incision. An extension of the shoulder joint will help in fracture reduction, and the use of pointed reduction forceps here is very helpful. Very rarely the humeral head growth plate fractures without the greater tubercle, in which case reattachment can be achieved via 2 parallel arthrodesis wires inserted from distal to the greater tubercle and directed caudally and proximally up into the humeral head. Reduction of this type of fracture can be very demanding and you may opt for amputation. No support dressings are used post-operatively, but a 4-week spell of strict rest would be employed. I don't have an X-ray of parallel pins and the tension band repair of a greater tubercle humeral head fracture, but this diagram illustrates the principle. Here we have the humeral head and greater tubercle. This is a physis or growth plate. This is the cranial aspect of the humerus, and here the caudal aspect. We have 2 black arthrodesis wires going from proximal to distal through the greater tubercle and into the humerus. Here we have orthopedic wire in a tension band pattern, figure of 8, and this counteracts the pull of the supraspinatus muscle on the greater tubercle. This is an example of a humeral head physial fracture that does not involve the greater tubercle. You can see the greater tubercle is intact, but the humeral head has come away from the humerus, and it's quite obvious here. This would be incredibly challenging to repair, and in this case I would opt for a 4/4 amputation. And just as an aside, when performing forelimb amputation, I prefer the 4/4 technique where the scapula is also removed. It involves less cutting of muscle and bone than going through the proximal humerus, and so it should be less painful for the animal. The one argument against it is that the scapula provides some protection to the craniothoracic wall, which might be worth considering if the animal is to be returned to the streets. In underweight or very thin dogs, perform a 4/4 amputation, otherwise you will end up with chronic open pressure sores over the bony prominence of the acromion. Fractures of the humeral shaft. Metaphyseal and proximal third fractures are very uncommon due to the large width of the proximal humerus. If you see a fracture in the metaphyseal region of the humerus of an adult dog, then consider the possibility of a pathological fracture secondary to osteosarcoma. The proximal humerus is a predilection site for osteosarcoma. If there's any doubt, X-ray the contralateral humerus for comparison of bone appearance. I don't have an image of a proximal humeral shaft fracture, but this is one of an osteosarcoma in the area, which often predisposes to pathological fractures here. This tumour is actually mid-shaft, which is unusual. They're almost always in the proximal third of the bone in this area. Most humeral shaft fractures occur in the middle or distal thirds. Conservative management of humeral fractures is rarely indicated due to the difficulties of immobilizing this part of the limb. The only exception would perhaps be greenstick diaphyseal fractures and minimally displaced proximal physeal fractures in young dogs. Open fractures are uncommon due to the large amount of soft tissue surrounding the bone. The humerus as a whole can be a tricky bone to deal with on account of its twisting anatomy. Contouring bone plates to the curves of the bone is difficult, and the medullary cavity ends distally well before the end of the actual bone itself, meaning that it's not the ideal bone to use an IM pin with. We will look at the repair of relatively simple transverse, oblique or spiral fractures of the humeral shaft. The much more complex supracondylar and condylar fractures of the distal humerus require more advanced internal fixation methods and are beyond the scope of this talk. With these more simple fractures of the shaft, we aim for anatomic reconstruction of the bone with immobilization using either an intermedullary pin or external skeletal fixator with cerclage wire in long oblique or spiral fractures, or an IM pin with ESF in short oblique and transverse fractures. In more comminuted mid-shaft fractures where reconstruction is not possible, we can again look at a combination of an IM pin and a more rigid ESF than we would apply with a reconstructible fracture. Plates of various descriptions are commonly used in humeral fracture repairs, but again we're not discussing plating principles here today. The anatomy of the soft tissue structures around the humerus also make this a difficult bone to approach. The radial nerve crosses the distal humerus from caudal to cranial on the lateral aspect, shown in the image here. The median and ulnar nerves must be protected if you're approaching from the medial aspect, along with the brachial vessels. In all likelihood, you'll be approaching the humeral shaft from the lateral aspect, and most of the length of the humerus can be accessed with a craniolateral approach, reflecting the triceps muscles caudally and the biceps brachii, pectoral and brachiocephalicus muscles cranially. The radial nerve and brachialis overlie the distal third, and they can be reflected either cranially or caudally depending on the location of the fracture. This will give you access to most of the humeral shaft except for the distal quarter. I'm not going to get into the anatomy too much, other than to say get yourselves a good surgical approaches to the bones guide or download one from the internet and have it in theatre with you for every orthopaedic operation you do. I still review my anatomy before every fracture repair. IM pins can be used, as mentioned, in long oblique and spiral fractures of the humerus in association either with cerclage wires or with an external skeletal fixator. Take care when placing cerclage wires on the humerus, since the bone is thicker at the proximal and extreme distal thirds, and it's thinner in the middle. And this means that unless fully secure, these wires will have a tendency to slip or migrate downwards or upwards towards the thinner bone. Because the main medullary canal of the humerus finishes at the level of the supratrochlear foramen, this effectively reduces the length of IM pin that we can use, meaning this technique is better suited to midshaft or more proximal fractures. It is possible to advance an IM pin into the medial aspect of the condyle in dogs, so if you're dealing with a distal shaft fracture, measure the pin diameter against the medial condyle diameter on the x-ray and aim to seat it there. You can't do this in cats. The medial condyle in cats is either too narrow or, in 40% of cats, it's completely closed. If the fracture of the humerus is more proximally situated, then I'd aim to place a thicker pin and have it seated in the bone proximal to the supratrochlear foramen. The pin is not as secure here as in the medial condylar bone, but with additional cerclage wire or ESF it should remain stable. Retrograde insertion of the pin, that is, inserting the pin at the level of the fracture site and directing it proximally, is usually required in humeral fractures due to marked distraction of the fracture ends. And you want to aim the pin cranially and laterally from the fracture site in order to avoid the articular surface of the humeral head and ensure that the pin is driven into the medial condylar bone when it's advanced distally. So this is the elbow, this is the paw, this is the shoulder, and we're aiming this pin in a sort of cranial direction within the medullary cavity to avoid the humeral head, which is here. Normal grade pins are started at the craniolateral aspect of the greater tubercle and driven down distally to the supratrochlear region for proximal and midshaft fractures, or a thinner pin driven into the medial condyle for distal fractures. For this latter procedure, we aim the pin to the medial aspect of the shaft, and we even bend the bone segments medially slightly to encourage it to go into the medial condyle. Here are two craniocaudal and mediolateral views of humeral IM pin cases. The one on the left has that IM pin seated correctly in the bone of the supratrochlear region. The image on the right, the pin has been advanced too far and will have entered the supratrochlear foramen, or in cats, they have a supracondylar foramen proximal to the medial condyle. The median nerve and brachial artery lie in this foraminal area, so there is a risk of damage to these structures if the pin enters this region. Pins can also be driven in a normal grade fashion from distal to proximal for distal humeral fractures, starting at the medial condyle and driving the pin proximately across the fracture site and into the greater tubercle. The pin is grasped as it exits the greater tubercle, the point is removed from the pin distally and the pin pulled up until it is buried within the medial epicondyle. And the final method is retrograde insertion of the pin in distal third fractures through the medial condyle. The fracture is then reduced and the pin advanced proximally as before, and this method allows assessment of the medial condyle accurately. IM pins are cut as close to the bone proximately with bolt cutters as possible, or left long to be bent round as connecting bars for an ESF, or for attaching an ESF connecting bar by means of another short bar and epoxy putty. External skeletal fixation is often used in humeral shaft fractures to provide stability in addition to an IM pin where plating is not an option. The humerus unfortunately does not lend itself well to ESF placement due to the medial aspect being in close association with the thorax, and also due to the large soft tissue covering and presence of major neurovascular bundles that we've got to avoid. Safe corridors for ESF pin placement in the humerus are craniolaterally in the proximal diaphysis and distally over the lateral epicondyle and lateral condyle, and only at the level of the medial humeral condyle on the medial aspect of the bone. The midshaft of the humerus laterally is out of bounds on account of the muscle covering and presence of the radial nerve. This X-ray shows a type 1A ESF supporting an IM pin repair of a short oblique midshaft humeral fracture, and there is one half pin placed proximally and two half pins placed distally. A type 1A ESF will prevent rotation, shear and axial compression forces in a non-reconstructible fracture when combined with an IM pin in the humerus. This ESF can be tied into the IM pin, which is left exposed as it exits the proximal humerus, or it can be a separate construct. It's not shown in this X-ray, but this is the IM pin, this is a connecting bar for the ESF, and these two can be joined out with the body by either epoxy putty or clamps. If you're not confident that your IM pin has seated well in the distal humeral diaphyseal bone, then by tying it to the ESF, it will help prevent IM pin migration proximally and increase the stability of the fracture repair by up to 30%. When used with or without an IM pin to stabilise a more comminuted fracture which is not reconstructible, then a more robust external skeletal fixation device is required. Ideally a modified version where the extreme distal pin passes through the humeral condyles from lateral to medial on a curved connecting bar linking the pin as it exits the medial condyle to the connecting bar proximally on the lateral aspect. The pin passing through the humeral condyles is described as a full pin, and ideally it should be a positive mid-threaded pin. With these more comminuted fractures, it's important to remember that we want to disturb the fracture site as little as possible in order to retain soft tissue attachments and blood supply to the small fragments present. And because of the amount of soft tissue that surrounds the humerus, there's an increased morbidity associated with ESF constructs in comparison with those placed below the stifle or elbow joints. Pin tract infection and pin loosening will be more likely to occur. This X-ray shows a more rigid ESF applied to a humerus to support a lag screw repair of an oblique humeral fracture. There are two half pins proximally, and a half pin and a full pin placed distally. The full pin crosses the humeral condyles and exits medially and is connected to the lateral frame with a connecting bar. The positioning of this X-ray doesn't help, but the second of the two pins in the proximal segment, this one here, looks to be placed a little too near the midshaft area, so we would expect some soft tissue complications here. With this fracture repair, it was decided to reconstruct the two major segments with a single lag screw and supply a more rigid external skeletal fixation frame rather than use an IM pin and simpler ESF frame. In the situations that you'll be presented with, it's more likely you'll opt for an IM pin and external skeletal fixator. Here are a few of those images again, illustrating that an external skeletal fixator can only be applied laterally to the humerus except the extreme distal medial aspect at the medial condyle. An ESF can be used to support IM pins or screw or wire repair of fractures. This image on the left, again, this pin is too near the midshaft of the humerus, so we can expect soft tissue complications. Ulnar fractures. Fractures of the olecranon are avulsion fractures due to the pull of the attached triceps muscle and tendon. In our situation, we can repair these using two arthrodesis wires and a figure-of-8 tension band with orthopedic wire. If the fracture is quite distal, then it will be intra-articular, and in an ideal world we would look at using plates and screws to repair this and reconstruct the joint surface perfectly, aiming for primary or direct bony union. The olecranon is a particularly tough, solid piece of bone, and it might require pre-drilling with a drill bit of smaller diameter than your arthrodesis wire if we're dealing with a mature dog. It may be easier to reverse drill and retrograde place the wires in the proximal olecranon segment to ensure that the arthrodesis wires pass into the central medullary canal of the distal segment once the fracture is reduced. The ulna has a particularly narrow medullary canal. Reverse drilling means drilling from the fracture site proximally. It's important to avoid the arthrodesis wires being aimed too cranially if you're inserting them in a normal grade fashion, because they may enter the elbow joint. This is that fracture that you saw in the previous slide, mediolateral and craniocaudal views, and it's been repaired with two arthrodesis wires and a figure-of-8 tension band using orthopedic wire. Ulnar shaft fractures are rare without associated fractures of the radius. An ulnar shaft fracture on its own is usually treated conservatively since it's not a weight-bearing bone and it will be splinted by the intact radius. Even with accompanying radius fractures, the ulna is often treated conservatively. In larger dogs, it is possible to pin the ulna to provide additional stability to a radial fracture repair, and it can be pinned in either a normal grade, that is from proximal to distal, or a retrograde fashion. As you can probably tell, this is not an ulnar fracture, but rather an osteotomy of the ulna created to treat an elbow condition and then partially stabilised with an IM pin. I don't have an x-ray of an ulnar fracture with an IM pin, but this is the general idea. Proximal ulnar fracture with luxation of the radial head. These are very specific injuries called Monteggia fractures, and they are usually repaired by plating or pinning the ulna and replacing the radial head and supporting the limb with a spica splint. If the radial head remains obviously unstable, then a position screw is placed between the radius and the ulna for support. Removal of this screw after 6 weeks might be necessary if pronation, supination is desired, for example with cats who use this function a lot. In our situation, where we've got limited or no access to plates and screws, then repair of anything other than a very simply reconstructed Monteggia fracture with stable radial head after repair will be a difficult task. This image here on the right is one that I borrowed from the internet, and it's a Monteggia fracture in a 5-month-old puppy. You can see the very obvious ulnar fracture and displacement of the proximal radius cranially. But look closely and you'll see the actual radial head has not luxated, but instead there is a physial fracture with the head of the radius remaining congruent with the joint. Now this may reduce nicely when you reduce the ulna, but if not, then in our hands we're probably looking at an amputation. Radial fractures are common and often affect the middle and distal thirds of the bone. They're often open fractures, unlike those of the humerus. Stable, non-displaced fractures may be candidates for external coaptation, although I would only consider this in young patients with stable, minimally displaced fractures, such as green stick fractures. The distal radius in very small and toy breed dogs is well known to be overrepresented when it comes to non-unions and delayed unions, so I wouldn't be tempted to use external coaptation in these breeds at all. Fractures of the distal radius tend to be transverse, short oblique, or comminuted. The shape of the bone means that long oblique and spiral fractures are unlikely. It is a bone that lends itself perfectly to plates and screws, and where the use of IM pins is not possible. And so in our hands, we are looking at trying to repair long bone fractures of the radius using simple external skeletal fixators. I've included this slide simply to illustrate the typical way we would repair a distal radial fracture in a 2 kg adult toy breed. And typically that would be using dynamic compression plates with the addition of bone graft material. Years of delayed unions and non-unions have taught us that this particular type of fracture is not very forgiving and it needs every possible helping hand to repair it. If this presents to us in the field, it's a good example of a fracture that we're unlikely to be able to repair and where amputation may be the best option. Top left here we have the obvious fracture. Here we have reduced the fracture and we're holding it in reduction before the application of a bone plate and screws, and the granular material you see here is an additional bone graft. Fractures of the radius are often repaired with either plates and screws or an external skeletal fixator. IM pins are never used in the radius since the medullary canal is very narrow and it's not possible to place an IM pin without entering the carpal joints. So do not try to place an IM pin in a radius. Most simple radial fractures that are not badly comminuted, I would opt for compression plating simply because the bone lends itself to this method and the surgical approach and exposure is quite simple. ESF is perfectly acceptable too, and often the only option in open fractures, badly comminuted fractures, and distal fractures where there is not enough bone stock for a plate. This X-ray here also illustrates a point made recently about ulnar shaft fractures being left to heal conservatively. They will normally come into excellent reduction themselves as the radius is reduced. Type 1A ESF constructs with a minimum of 2 pins and a maximum of 4 pins above and below the fracture site would be suitable for young patients or small dogs and cats. Place the ESF pins in an oblique position, either craniomedially or craniolaterally, since this allows larger ESF pin diameters to be used than when applied in a medial-lateral plane where the bone is narrower. And remember that our ESF pin should not exceed 25% of the diameter of the bone, and so if we place these obliquely, then we're working with a much larger diameter of bone, which allows us to place thicker pins. Here we have a craniomedially applied type 1A ESF to the radius of a dog. We've got mediolateral and craniocaudal views, and these are all half pins. And here on the right we have the image with the connecting bar on the medial aspect of the radius of this dog. In larger dogs or mature dogs, opt for a type 1B ESF construct with half pins placed in both a craniomedial and craniolateral plane. Again, shared between the two connecting bars, we require a minimum of 2, but preferably in a larger or mature patient, 3 or 4 pins in each segment. Type 2 ESF constructs utilising full pins I would avoid, since it means placing the pins in the medial-lateral plane of the radius, which due to the narrow width of the bone in this plane predisposes to fractures through the pinholes. The proximal radius has a good muscle covering, so limited approaches to the bone will be needed in order to place your pins, so use a drill sleeve if you have one. It's very probable that you'll need to make a limited open approach to the fracture in order to confirm reduction prior to fixing the connecting bars to the ESF pins with your epoxy putty. Joining the two separate connecting bars in a type 1B ESF will further increase stability. Here we've got a craniomedially and craniolaterally applied type 1B ESF to the radius of a dog. Here on the craniomedial aspect we've got 1, 2, 3 half pins connected to a carbon fibre connecting bar which you cannot see. On the craniolateral aspect we've got 1, 2, 3, 4 half pins connected to a steel connecting bar. We also have a clamp here and a clamp here, and between these two clamps connecting the two connecting bars is another carbon fibre bar. So you can see the fracture site is here, so we've got 1, 2, 3 pins distally and 1, 2, 3, 4 pins proximally shared between the two connecting bars. Distal radial growth plate or physeal fractures are approached using crossed arthrodesis wires as already discussed. Something that is relevant with these fractures in very young dogs is that premature closure of radial or ulnar growth plates in this area, even with early pin removal, can lead to significant deformity and associated elbow pain as the animal reaches maturity. My advice would be to repair the fracture, remove the implants after 4 weeks if possible, and hope for the best. At least you're giving this dog the chance of keeping its leg. Remember that this epiphyseal bone will be very soft in young animals, and trying to bend the pins back like this, you may create an oval hole and lose some stability. So for that reason, I sometimes simply cut off the pins flush with the surface of the bone. Pelvic fractures. This is not really on our agenda, but since many road traffic accidents will have some degree of pelvic fracture, I'll make reference to these. In our situation, we will be treating these conservatively, but in any case where there's a hind limb fracture or dislocation, I would advise x-raying the pelvis too, and take two views, a mediolateral and a ventrodorsal one. Many pelvic fractures are amenable to conservative treatment, but there's 3 main categories I suggest that will do poorly with a conservative approach, and these are, firstly, those with intra-articular acetabular fractures. These cases may need femoral head excision or limb amputation later if the hip joint becomes non-functional. Second category are those where the pelvic canal has been narrowed by over 50%, and that should be reasonably easy to see on a ventrodorsal x-ray. And thirdly, those where there is major disruption in the main weight-bearing axis of the pelvis. This x-ray here is of the normal pelvis of a puppy, so don't confuse growth plates with fracture lines. And I've included this simply to illustrate what I mean by the main weight-bearing axis of the pelvis, which I've highlighted in red. And it comes through from sacrum, through sacroiliac joint, down through the ilium and into the acetabulum. And from then on, obviously, down through femoral head and through femur. These images both represent pelvic fractures that may do poorly with a conservative approach. The one on the left has bilateral sacroiliac subluxations which, on one side in particular, represent a disruption in the main weight-bearing axis. However, there's no acetabular involvement and no significant narrowing of the pelvic canal, so I would definitely give this animal a chance conservatively. In an orthopaedic clinic, we would look to stabilise this major sacroiliac subluxation with a screw. The case on the right, however, carries a very poor prognosis. Not only is there significant disruption of the weight-bearing axis of the pelvis on both sides, and we can see we've got multiple fractures here and a sacroiliac subluxation here, but the pelvic canal has been completely obliterated and there's also an acetabular fracture. This case will likely require euthanasia on humane grounds. Don't be performing heroic orthopaedic surgery on an animal's femur or tibia if the pelvis looks like this. Traumatic hip luxation. This often occurs after major trauma such as a road traffic accident or a fall from a height. It can occur with or without accompanying fractures. The golden rule, as with all traumatic luxations, is that you must x-ray the area to ensure there are no fractures before you start manipulating bones back into place. 2 x-ray views need to be taken to confirm the direction of the luxation, although this is normally in a cranio-dorsal direction in the hip. Caudodorsal and caudoventral luxations are also possible. A dog with a dislocated hip will be 100% lame, it won't be weight-bearing, and palpation alone in a thin dog will show differences between the triangle of bony prominences of the iliac crest, ischiac tuberosity and greater trochanter. And with craniodorsal luxations, the greater trochanter is palpably further cranial and dorsal to the normal side. These images show a typical craniodorsal luxation of the hip in a dog with the 2 standard views needed to confirm this. Here we've got our ventrodorsal view with cranial movement of the femoral head, and here we have lateral view which confirms the dorsal movement of the femoral head, so we know this is a craniodorsal luxation. Closed reduction of the luxated hip should be attempted as soon as possible after the injury, and in craniodorsal luxations it's achieved by rotating the limb externally whilst at the same time applying distal traction. It helps to place a towel or a band of some sort under the normal hind limb during the procedure to counteract the traction. When maximum traction is achieved, internally rotate the femur to encourage the femoral head to pop back into the acetabulum. I find it helps to also push firmly on the greater trochanter to try and pop the femoral head back into the joint as you internally rotate the femur. If the hip does relocate, then flex and extend it while applying downward pressure to try and dislodge any hematoma or joint capsule that may be in the acetabulum. After reduction, it's recommended to place the limb in an Emmer sling for 7 to 10 days to help prevent reluxation. Personally, I've seen more poorly placed Emmer slings than correctly placed ones, often resulting in more serious injury than the original hip luxation. So if you do use an Emmer sling, then the patient must be hospitalised and the foot checked twice a day for any evidence of swelling or circulatory compromise. Many hips will reluxate readily, and these will then require an open approach and surgical repair, which is not something we're going to talk about here. This injury can be the consequence of an incorrectly applied Emmer sling, or an Emmer sling that was correctly applied but then not monitored properly. Femoral head and neck osteotomy. Whilst this is not a fracture, I think this is worth covering briefly because it might be the only option you have in your clinics for dealing with a reluxated hip joint, and it's definitely preferable to performing a complete hind limb amputation. The instruments required are minimal and include an osteotome, an orthopaedic hammer and a pair of rongeurs. We would tackle this surgery via a craniolateral approach to the hip, and you can get that from textbooks, which means that we are sparing the gluteal muscles, we're not transecting them. It's often necessary to cut a portion of the deep gluteal tendon and scrape the vastus lateralis attachment off the femoral neck so that we can visualize where we want to make our osteotomy. One or two pairs of Gelpi self-retaining retractors and a Homan retractor are invaluable here. Externally rotate the femur until the patella is pointing directly at the ceiling, and the osteotomy is made perpendicular to the tabletop across the femoral neck to the level of the lesser trochanter on the medial aspect of the femur. Post-operatively, we want to encourage very early mobilization and use of the limb in order to maximize our results. In general, the longer a dog has not used the leg, and therefore there's a lot of muscle wasting, the poorer the prognosis for an early return to some form of function here. These X-rays illustrate a cranio-dorsal hip luxation and a post-surgery image after a femoral head and neck osteotomy showing a clean osteotomy line from the greater trochanter to the lesser trochanter. So why does this surgery work? Because a pseudoarthrosis or false joint is formed between the smooth femoral shaft and pelvis, and as long as we don't have bone rubbing on bone, we would hope for a decent degree of return to function. Potential complications of the surgery include iatrogenic fracture of the femur and leaving excessive amounts of femoral neck in situ. Minimal instrumentation is required, as we've already mentioned, and that would include an osteotome, an orthopedic hammer, rongeurs, and some Gelpi self-retaining retractors. Growth plate fractures of the femoral head, or capital physeal fractures. Capital physeal fractures occur through the growth plate of the femoral head in young animals, and they can be difficult to see on X-rays if there is minimal separation of the segments. Here you can see clearly there's a fracture line through the physis, with the femur displaced cranially and the femoral head remaining within the acetabulum. It is possible to repair these using parallel arthrodesis wires, although surgery needs to be done very soon after injury. The same approach to the hip joint as with femoral head and neck osteotomy is used, and the hip is externally rotated. The fragment is left attached to the teres ligament, and arthrodesis wires are inserted in a retrograde fashion through the physis on the femur and exiting the lateral aspect of the femur below the greater trochanter at the level of the third trochanter. The fracture is then reduced and the wires driven into the fragment. Measure carefully on pre-op X-rays and palpate the surface of the femoral head with a fine instrument to ensure there is no penetration of the pins into the joint. Bend the pins back with K-wire benders as they exit the bone and advise strict rest for 3 to 4 weeks. I find these surgeries quite challenging and fiddly, and certainly in cats and very small dogs, femoral head and neck osteotomy will very likely give satisfactory results. Here is that case you've just seen, repaired with 2 arthrodesis wires. This is a cat. We always use a minimum of 2 wires in order to neutralize rotation forces at the fracture site. I think that the majority of these injuries in cats and small dogs should probably undergo a femoral head and neck osteotomy in the street dog population. Why? Because it's simpler and quicker to perform, and there are no post-op exercise restrictions, and the patients also tend to do very well. Femoral neck fractures. Again, these are more common in young patients, and again in our circumstances, fixation can be attempted by driving arthrodesis wires from the area of the third trochanter, which lies distal to the greater trochanter, through the femoral neck and into the femoral head. We use the craniolateral approach to the hip joint, and retrograde placement of the pins may be helpful. These can be challenging fractures, and again it might be that a femoral head and neck osteotomy will provide a more rapid and complication-free return to a pain-free and functional limb. With both capital physeal and femoral neck fractures, anatomically it makes sense to try and reconstruct the hip, but in all reality we're dealing with predominantly a street dog population, and, as mentioned, a well-positioned femoral head and neck osteotomy will usually provide a satisfactory return to function in the quickest timescale. The other advantage of femoral head and neck osteotomy is that we do not require 4 to 6 weeks of strict rest post-operatively, something that needs to be taken into account with our street dogs. There should be no reason to amputate a hind limb in case of hip luxation, capital physeal fractures or femoral neck fractures. Femoral head and neck osteotomy, although regarded as a salvage procedure, is also a limb-saving procedure. Diaphyseal fractures of the femur. Like the humerus, the femur has good muscle and soft tissue covering, and being so close to the body wall makes it a poor candidate for external skeletal fixation alone, because access to the medial aspect is simply not feasible. As with the humerus, external coaptation is not suitable for the femur for the same reasons, including difficulty in immobilizing the limb and the overriding of fragments due to the great forces involved here. External coaptation is only really suitable for fractures below the elbow and stifle, and even then it's better applied to non-displaced fractures that are reasonably stable, particularly young animals with a rapid healing potential. Similarly to the humerus, open fractures are a lot less common than with the radius ulna and tibia, although the muscle covering means that there's good potential for secondary or indirect bony healing if we leave this soft tissue envelope alone as much as possible. The major nerve here is the sciatic nerve, which courses dorsal to the acetabulum and runs caudally to the greater trochanter and femur beneath the biceps femoris muscle. The craniolateral approach to the hip joint previously discussed is preferred for two main reasons. It minimises the amount of muscle that requires to be transected to access the hip joint, and it allows us to work away from the field of the sciatic nerve. The surgical approach to the femur is laterally, where after incision in the fascia lata, the biceps femoris is retracted caudally and the vastus lateralis, which is the branch of the quadriceps, is reflected cranially. Care is taken to protect the sciatic nerve when retracting the biceps femoral muscle. The large adductor muscles attach to the caudolateral aspect of the femur, and it's important to try and preserve this connection site, since this muscle is an important blood supply to the bone. Once again, it's essential to refer to texts or online guides for accurate descriptions of surgical approaches. The femur lends itself well to fixation using intramedullary pins, since the proximal joint surface, that is the femoral head, is situated well away from the long axis of the bone. IM pins should never be used alone, but in conjunction with cerclage wire in long oblique and spiral fractures, or a laterally applied external skeletal fixator, which can be tied in or not to the IM pin for comminuted or short oblique and transverse femoral fractures. The femur is a good bone to apply a plate and screws to, but we will not be discussing this just now. Intramedullary pins can be placed retrograde or normograde, as with the humerus. For retrograde placement, extend the hip and hold the limb in adduction to reduce the risk of sciatic nerve trauma as the pin emerges from the trochanteric fossa. With direct pinning, which is preferable, the pin is walked off the medial edge of the tip of the greater trochanter until it drops into the trochanteric fossa. Once into the medullary canal, the pin is advanced distally until it makes contact with the cranial cortex in the region of the trochlear notch. Due to the cranial bowing of the femur, the IM pin will not seat down in the femoral condyles. The pin can be withdrawn, cut and then countersunk, or simply cut off as short as possible to the bone in order to minimize the incidence of sciatic irritation. I prefer to seat the pin in the cortex with a few turns and cut it off proximally. I'm concerned that if I cut and countersink, the trocar tip is not gripping into the bone distally. IM pins can easily be removed in adult animals if they cause irritation, although in young animals, long bone growth often makes it impossible unless the pins migrate. Placing the IM pin first helps with the alignment of the femoral fragments prior to placing your additional implants, cerclage wire or an ESF. The IM pin can be placed using either an orthopedic drill or a hand chuck. When placing IM pins normograde, the use of the drill is required. The use of an IM pin with cerclage wire. Using the principles already discussed for cerclage wire, the femur is an easier bone to use this technique in than the humerus due to its uniform diameter throughout, and so there's less risk of cerclage wire slippage occurring. Remember that this bone gets good blood supply from the adductor muscle attaching caudolaterally, so try to preserve this at all costs. Either twist the wire while folding it down against the bone, or cut it short leaving 3 to 4 twists as we've done here. This latter technique is easy to do when applying cerclage wire to the humerus and femur, since there is a lot of soft tissue covering, and so the wire end standing proud will not irritate overlying skin. It will also provide a more secure support, since bending always introduces the risk of the wire loosening by up to 70% as you bend it over. IM pin use with an external skeletal fixator in the femur. Similarly to the humerus, the femur is not great for using ESF constructs. We only have access to the lateral aspects, and as with the humerus, the most proximal and distal aspects of the bone are where we want to place our ESF pins. Again, similarly to the humerus, the most distal pin in the femur can be placed as a full mid-threaded pin, exiting on the medial aspect of the stifle joint and connected via a diagonal connecting bar to the connecting bar on the lateral aspect of the bone. That is, this pin could come all the way through and be connected by a connecting bar from here up to here. Pin tract problems and pin loosening are common when using an ESF on the femur, particularly distally as we approach the stifle joint on account of the amount of movement of soft tissue that is present in that area. Now, ultimately, in a large adult dog with a femoral fracture, internal fixation using dynamic compression plates, locking plates, or plate rod constructs are preferable due to the forces acting on the fracture site. IM pins with additional ESF or cerclage wires may not represent a stiff enough fixation in these cases, since their implants may fail before the fracture has had time to heal. And by failing, I mean an IM pin could migrate, or you could get ESF pin loosening. These techniques would be more likely to succeed, I think, in younger or smaller dogs and cats. Having said that, we have to work with what we've got and what we've experience of using. The use of the external skeletal fixator will combat rotational, compressive and shear forces at the fracture site, none of which are addressed by the IM pin alone. Remember, IM pins are very good at resisting bending forces, but little else. The IM pin can be tied into the external skeletal fixator, as with humeral fractures, and this will increase stability. So here we have our intermedullary pin, and it's tied in to the connecting bar of this type 1A external skeletal fixator. If the femoral fracture is not reconstructible, we will need a more rigid external skeletal fixator to support our IM pin, and ideally in this case we would want 2 ESF pins proximal and 2 distal to the fracture. A full ESF pin can only be placed through the femoral condyles, and we need to use a mid-threaded pin for this. You cannot place a full pin through any other area of the femur. We definitely see increased morbidity with external skeletal fixators in the femur due to the amount of soft tissues present. I have placed modified type 2 ESFs in the femur before with a positive threaded pin, full distal pin through the femoral condyles, but these are associated with so much morbidity due to soft tissue movement in the area that I nearly always use alternative methods of fixation here, such as bone plates and screws. Femoral fractures occurring very proximally, as we can see in these two x-rays here, are difficult to stabilise effectively with IM pins due to the forces acting on the bones here, as are fractures that occur extremely distally, excepting that is for distal femoral growth plate fractures, which we'll cover shortly. There is often just not enough bone stock present above these fractures for the IM pin to provide suitable stability and limited options for ESFs to be placed. And these are the fractures where specialised plating plays a large role. But in our hands, there will be many that are just not repairable with the methods we have, and so amputation would be recommended. Distal femoral physeal or growth plate fractures. These x-rays illustrate this type of fracture. Here we have a lateral view with a fracture line. This is a craniocaudal view, and you can see the very obvious fracture line here. And this is another lateral view, which is slightly harder to figure out. Our femoral condyles are sitting here instead of where they should be here at the end of the femur. These are not uncommon fractures in young animals, and we would aim to repair these as soon as possible after the trauma using arthrodesis wires in a cross-pinning fashion, as we've already described. The distal femoral physis is a very irregular shape, which actually helps us in maintaining reduction and combating shear forces. The distal segment is always pulled caudally and dorsally by the muscles, and so we must reposition it on the end of the femur whilst handling the growth plate surfaces as little as possible. Under-reduction is the commonest issue with repair of these fractures, so aim to slightly over-reduce the fracture when you place your cross pins and ensure the pins cross proximal to the growth plate. This would be under-reduced if it was fixed in this position. Normal reduction would be here, over-reduction, the condyles would be slightly higher up. If maintaining reduction of the fracture is proving difficult, then you can drill a small hole in the cranial cortex of the femur round about here and use your pointed reduction forceps between this and the intercondylar notch of the femur to help. This is a distal femoral physial fracture in a young dog, which has been repaired with not 2 but 4 arthrodesis wires in a cross-pinning fashion. 2 cross pins should be adequate, 1 from either side, but in large, robust, bouncy dogs it may be safer to place more. Remember, however, that the more pins you place, the more damage you will create to the physis, the growth plate. But the fracture has to be stable, so that's our immediate priority. In a very young animal with a lot of growing to do, I would place as few wires as possible, whereas in a large, bouncy dog with limited growth potential left, I'd be tempted to place more than 2 and aim for better stability. Avulsion fractures of the greater trochanter. These are femoral fractures which are seen occasionally in young growing animals, and repair is undertaken using 2 parallel arthrodesis wires and a figure-of-8 tension band wire to counteract the pull of the gluteal muscles. With very young animals with a lot of growth potential left, remove these implants after 3 to 4 weeks in the hope of preserving some of that growth plate activity. Fracture disease. I've had 2 cases of fracture disease over the years, both affecting the quadriceps muscle. Fracture disease is a slowly progressive and irreversible fibrosis of the quadriceps muscle masses, which results in hyperextension of the stifle and a rigid and unusable limb requiring amputation. It occurs in young growing animals, both dogs and cats, where the limb has been immobilized or not used after surgery for a period of time. Postoperatively in young animals, to try and help prevent this, encourage an early return to function and perform daily passive range of motion exercises to maintain normal stifle function. Remove all external skeletal fixation equipment as soon as fractures have healed in young animals, since these are associated with a greater risk of fracture disease occurring. Tibial fractures. Fractures of the tibia are common and more likely to present as open fractures after a road traffic accident due to the bone's poor soft tissue covering. This poor soft tissue covering may also predispose the tibia to more problems with bone healing, particularly distally. The superficial saphenous nerve, which is sensory only, and saphenous artery and vein cross the medial tibia obliquely, so try and protect these if possible. The medial aspect of the tibia basically lies underneath the skin, so it makes the perfect approach for fracture repair. Tibial diaphyseal fractures commonly affect the middle or distal third of the bone, and due to the shape of the bone, the fractures are often spiral oblique in nature, although comminuted and transverse fractures also occur. Unlike the humerus and femur, a conservative approach, that is external coaptation, could be considered for stable, minimally displaced fractures of the tibia as long as both the tarsus and stifle are fully immobilized. A conservative approach would be applicable in young patients with a rapid healing potential with closed fractures. Care should be taken that support dressings are changed weekly under sedation to allow for the growth of the limb. Failure to do this might result in severe constriction with loss of blood supply, avascular necrosis of tissues, and ultimately amputation. Similar to the humerus and femur, we can use a combination of IM pins, cerclage wires, and external skeletal fixation constructs to repair tibial fractures. Simple long oblique and spiral fractures can be repaired with an IM pin or an ESF with cerclage wire. Simple short oblique and transverse fractures, we would look at using an IM pin with an ESF or an ESF alone. And comminuted midshaft fractures, we would be looking at using an IM pin with a more rigid ESF or a more rigid ESF alone. Intramedullary pins. The tibia can only be pinned in a normograde manner. Do not ever attempt to retrograde pin the tibia, or the pin will end up within the stifle joint. For the tibia, we use IM pins with a diameter of 50 to 60% of the medullary canal at its narrowest point. The point of insertion of the IM pin is adjacent to the medial border of the patellar tendon and approximately 1/3 of the way back from the cranial aspect of the bone. And I'll show you a diagram of this in the next slide. If you position the pin too cranially, it'll simply drive into the solid bone of the proximal tibia and tibial tuberosity. The pin is advanced distally through the medullary canal until it seats in the bone proximal to the talocrural joint, and then cut proximally as close as possible to the bone. The cutting and countersinking method can also be used, which will allow the pin to seat flusher with the bone, but this will make it difficult to remove if needed. When pinning any long bone, one option is to cut the trocar tip off the pin as it appears at the fracture site before driving it into the distal segment to prevent the pin entering the joint distally. This means it can't be seated as securely in the distal bone segment as with a trocar tip, and so it might be more likely to migrate. However, if we are using additional stabilisation in the form of cerclage wires and ESFs, then stability should be good and pin migration will be unlikely. With all IM pinning procedures, it's helpful to have other pins sterilised so that you can measure them against your implant at the time of surgery, and this will serve as a guide as to how close to the joint you are. Remember though that with the tibia, the medial and lateral malleoli extend beyond the talocrural joint surface, so don't use these as your guide to how far you can place your pin distally. This is a diagram to show where we start the normograde insertion of an IM pin in the tibia. This is a cross-section of proximal tibia, medial aspect, lateral aspect, cranial aspect with the tibial tuberosity and the caudal aspect, and the point of insertion is marked 1/3 of the way back. Using a power drill on low speed makes this fairly straightforward and will eliminate any pin wobble effect that we would see with a Jacob's hand chuck. The use of an IM pin with cerclage wire. The proximal tibia is not a good candidate for using cerclage wire. The bone is triangular in cross-section, and so the wire will have limited contact with the bone surface. Placing cerclage wire in this location also involves damage to the important muscle attachments and risks trauma to the tibial nerve and the popliteal and cranial tibial arteries in this location. And finally, the bone of the proximal tibia gradually narrows towards the midshaft, and so there's an inherent tendency for cerclage wire to slip distally. Cerclage wire can be employed more successfully more distally for long oblique spiral fractures or fissures, but it's not ideal due to the presence of the fibula. This picture is a poor example. This is actually a non-union where the IM pin was not long enough, and there was loosening of the cerclage wire, resulting in a loss of stability of this fracture repair. The use of an IM pin with an external skeletal fixator in the tibia. The X-ray image in this slide confusingly doesn't illustrate well what I'm going to discuss here, but I'll come to the X-ray at the end. When using an ESF to augment an IM pin repair of the tibia, we would apply it to the easily accessible medial aspect. Placing ESF pins past an IM pin in the distal tibia can be a real challenge, and as such, if a fracture isn't reconstructible using an IM pin and cerclage wire, then we would often opt for a more robust ESF alone in more complex fractures. The tibia is very well suited to ESF techniques for fracture repair. If we are placing a simple 2-pin type 1A ESF, that is just a single pin in both the proximal and distal segments, to augment a simple fracture repair with an IM pin, then some surgeons prefer to place the distal ESF pin first and then place a normograde IM pin until it reaches this point. Or if we're lucky, the IM pin goes past it and into the distal bone. If we're doing this, we need to place our ESF pin as distally as possible so that if it stops the IM pin advancing, then we still have a good working length of IM pin in the distal tibial segment. Now this would be fine for younger animals with relatively simple fractures, but it won't provide enough stability for more complex fractures in older patients. An IM pin with a 4-pin type 1A ESF meaning we've got 2 ESF pins in both the proximal and distal segments, would be suitable for simple transverse or oblique tibial fractures. This image here is a modified type 2 ESF, that is, we've got a connecting bar on both sides with an IM pin. And this is a cat that had both proximal and distal fractures of the tibial diaphysis. And the proximal pin here exits on the lateral aspect of the tibia, which is not ideal due to the soft tissue coverage. But I've put this X-ray in just to show that sometimes we need to break the rules in order to achieve stability. As we've just said, placing ESF pins past an IM pin in the distal tibia can be a real challenge. And as such, if a fracture isn't reconstructible using an IM pin and cerclage wire, then we would often opt for a more robust ESF alone in some simple and most complex fractures. Unlike with the femur and humerus, but in common with the radius, tibial fractures can be approached using an ESF construct alone. This bone is the easiest of the long bones to apply an ESF to. The whole of the medial and cranial aspects of the bone are suitable for half pin placement, and the distal half of the lateral aspect can be used if incorporating a full threaded pin in the construct, for example a modified type 2 device. We avoid the lateral aspect of the tibia proximally due to the presence of the cranial tibial muscle, unless of course you have absolutely no other options, as with the image on that last slide. Again, when placing distal ESF pins, remember that the talocrudal joint surface lies proximal to the level of the tibial malleoli. We use ESF pins 20% of the diameter of the tibia. An ESF alone would be used for comminuted unstable tibial fractures or in minimally displaced fractures in young animals. This is a simple spiral oblique closed midshaft tibial fracture in a young patient. It was quite unstable and so not a candidate for external coaptation. It was also a cat and so definitely not a candidate for external coaptation. Due to the presence of the open growth plate at the proximal tibia, we opted to avoid using an IM pin and instead we applied a simple type 1A ESF to the medial aspect of the tibia, utilising 2 ESF pins in both the proximal and distal segments. It could be argued that cerclage wires may not have been necessary in a patient this young, but we used them via a limited approach. You can see that we bent the ends of the cerclage wires down here so that they're lying just beneath the skin. In the humerus and femur, better practice would be to leave them perpendicular to the bone and cut, leaving 3 to 4 twists. This slide shows a type 1A ESF applied medially to a cat's tibia, and on the right we have a type 1B ESF applied medially and cranially to a cat's tibia. And you can see here on the right that the 2 connecting bars have been joined proximally and distally with additional bars to increase stability. The image on the left is the X-ray you've just seen, and the one on the right was a cat whose tibia had been shattered by an airgun pellet. A high velocity open comminuted fracture that was very suited to the use of an ESF construct alone. And in this type 1B ESF we actually have 3 half pins in the proximal segment and 3 half pins in the distal segment. I rarely use type 2 frames in tibial fractures now, tending to prefer type 1A or type 1B frames applied medially and cranially. I'll sometimes use a modified type 2 frame, such as this one, for distal fractures in mature animals where bone stock is limited distally and where I have a full mid-threaded pin proximal and distal to the fracture, with the remaining pins being half pins from the medial aspect. Additional support can be achieved by using cranially inserted pins to create a type 3 ESF construct. We have to remember, however, though, that if we create a super rigid external skeletal fixation construct, we will have an incredibly stable fracture site which will not be prone to callus formation due to the lack of movement. If our fracture gap is large, then we will end up with a non-union. And I've fallen into this trap when applying a type 3 ESF to a mature cat, believing that I needed the construct to remain in place for probably about 4 months. Unfortunately, I stress protected the fracture site, and with the gap present, no new bone developed. I had to revise this surgery by freshening up the bone ends and removing some pins to create a less stable construct which allowed bony callus healing to occur. This X-ray shows a modified type 2 ESF. It's not a distal tibial fracture, but it's that image you saw before where there unusually are proximal and distal fractures going on. Severely comminuted distal tibial fractures can present a real challenge when we've only got access to IM pins and basic external skeletal fixation equipment. Again, amputation is very likely to provide us with the best and most humane outcome for the animal. There are other forms of ESF more suitable to extreme distal fractures where bone stock is limited, such as circular fixators and hybrid fixators, which we can see here. And this is a combination of a circular or ring fixator placed distally with a linear fixator placed proximally. Tibial tuberosity avulsion fractures. These are very common in young dogs and present as painful non-ambulatory lamenesses with swelling over the tibial tuberosity region. There's often no palpable instability. These fractures can heal themselves with strict rest, but they could also result in severe deformity if left untreated. And the good news for us is that these fractures can be repaired relatively easily. X-rays can be a little bit confusing, so always X-ray the contralateral side for comparison. This image on the left shows the normal growth plate appearance of the tibial tuberosity in this puppy, whereas on the right you can see the fracture segment being pulled away from the bone on the other tibia. If displacement is minimal, then cage rest for 3 to 4 weeks may suffice, but if lameness persists beyond 3 to 4 days or there is gross displacement of the tibial tuberosity, then surgery is usually warranted. If you've got the luxury of good X-ray facilities, then repeat X-rays 1 to 2 days after presentation will inform you whether or not the tuberosity is stable, or indeed whether it's being avulsed further from the tibia, in which case surgery is warranted. Surgical repair of these fractures involves the placement of 1 or 2 arthrodesis wires in a parallel fashion through the fragment and engaging the far cortex of the proximal tibia, secured with a figure-of-8 tension band wire, which should be removed after 3 to 4 weeks to try and prevent complete closure of the tibial tuberosity growth plate in very young animals. It's easier to repair these fractures with a stifling extension because this reduces the pull of the patellar tendon on the tibial tuberosity as you drill. We aim the arthrodesis wires slightly distally to ensure we don't damage the proximal tibial growth plate or even enter the stifle joint. On X-ray, these look very obvious fragments, but at surgery it can be difficult to see where the bony fragment lies due to the amount of soft tissue, cartilage and periosteal reaction. Use a fine gauge needle to identify the edges of the bony fragment and make sure your pin penetrates this in the middle and not near the distal tip, otherwise the fragment will break when force is applied. Pins are normally inserted just at or proximal to the insertion of the patellar tendon fibres, which can usually be seen as a faint horizontal band. Due to the small size of bony fragment, it's often possible to place only one arthrodesis wire, and the figure-of-8 tension band is placed around this and cranial to the patellar tendon. If the fragment will allow, and definitely in large breed dogs, I will always insert an additional smaller diameter arthrodesis wire as an anti-rotational device, medial or lateral to the main wire and slightly distal. The figure-of-8 tension band wire will be looped around a slightly proximal larger pin, and when twisting the wire here, I make a single twist on the lateral aspect of the tuberosity since there is more soft tissue here to cover the wire ends. In this repair on the right, the pins are well positioned in the centre of the fragment and away from the proximal tibial growth plate. The hole drilled in the tibia for the cerclage Y, however, is too near the cranial cortex and there will be a risk of this fracturing and losing the tension band effect. It could also have been drilled a little more distally. Remember, the distance from the fracture line to the hole should be the same as or larger than the distance from the fracture line to the pins. Proximal tibial physial fractures. This is where the proximal tibial physis slips backwards, usually in association with a tibial tuberosity avulsion. Hopefully performing a tension band repair of the tibial tuberosity as described before will pull the tibial plateau back into position. If not, for example, if the tibial plateau has moved laterally or medially as opposed to caudally, then it will need gently levered back into position and a couple or even one additional arthrodesis wire used to hold it in place with a cross-pinning method alongside the tension band repair of the tibial tuberosity. As with tibial tuberosity fractures, these are better repaired within 2 to 3 days of injury, otherwise our chances of success will diminish. In this X-ray, we've got a proximal tibial physial fracture with an associated avulsion of the tibial tuberosity, and it's been repaired using 2 arthrodesis wires with a figure-of-8 tension band in the tuberosity, along with an additional single arthrodesis wire inserted mediolaterally in a cross-pin fashion. Distal tibial physial fractures. Again, this is a fracture of young animals, and after reduction we aim to stabilise this type of fracture with arthrodesis wires placed in a cross-pin fashion from the medial and lateral or fibular malleoli. Identifying the point of the medial malleolus can be difficult, and the use of a fine gauge needle helps since it is covered by the medial collateral ligament. The needle will also help identify the talocrural joint space to aid in pin direction. So this is the talocrural joint, and this is our physial fracture here. And we want these pins to penetrate the cortex of the tibia proximal to the fracture site. These fractures may be minimally displaced if the fibula remains intact or as a green stick fracture, so examine X-rays carefully and use the contralateral leg for comparison. The amount of bone distally with this fracture type is minimal. Use a K-wire bender to bend the pins back at the distal aspect, or if the bone appears soft, then simply cut the pin flush with the bone surface. Bending the pins back creates a real risk of the pin breaking out through the malleolar bone. If the repair is not secure, then this may require external support for a week or 2. And remember again that all growth plate trauma can result in premature closure and significant abnormalities in bone growth as the animal gets older. Malleolar fractures. These are not particularly common. They are not growth plate fractures, but we repair them, as in the previous slide, with arthrodesis wires through the affected malleolus and into the tibial cortex on the far side. Now, due to the pull of the medial and the lateral collateral ligaments, we will need to use a figure-of-8 tension band wire in order to convert the distractive forces into compressive forces at the fracture site. Once again, it's advisable to use a 25 gauge needle to help identify the boundaries of the malleolus and where the joint space lies before inserting the pin. These fractures often benefit from some form of additional external support for several weeks. So, I hope this covers the basic principles of long bone fracture repair and will help identify the dogs and cats that we can help and those which would be better going straight to amputation. With the limited tools at our disposal, there's many fractures which frustratingly simply will not be reconstructable in our clinics. If you feel that the fracture in front of you does not have a very good chance of healing with the methods available to you, then it would be better to amputate for that animal. Here are just a few fractures that are not amenable to fixation using the techniques we've covered and that would do better with amputation. On the left here, we have a severely comminuted distal humeral fracture. In the middle, we've got a lateral humeral condylar and intra-articular fracture. The upper right X-ray, apologies for the poor quality of this X-ray, but this is a transverse femoral fracture. And the lower right picture is a severely comminuted distal tibial fracture. Now, looking at this femoral fracture and what we've been talking about, you might think that it would be applicable to repair this using an IM pin and an ESF applied laterally. Well, this is a mature giant breed dog, and so the forces acting at this fracture site will be immense. It is very unlikely that an IM pin ESF will last long enough without IM pin migration or ESF pin loosening to allow this fracture to heal. It would be much better in this individual to reconstruct the bony column and apply a dynamic compression plate and screws and aim for primary or direct bony healing with implants that will stay in place long enough for this to occur. In a smaller dog or cat, then an IM pin with ESF could be used, but in a large or giant breed dog that is very active, then we probably are asking too much of our implants. And look at this tibial fracture here. You could say to yourself, I could have a go at repairing that with an ESF applied to the cranial and medial aspects. I think there's enough room in the distal bony segment to get 3 pins in there. We'll have a look at this next slide. We need to think again because this patient is actually a rabbit, and applying an ESF to a rabbit is not an option. Also, the forces that will be applied through this bone when the rabbit jumps or kicks will almost certainly be greater than our ESF could withstand. The leg was amputated and this rabbit did very well. The message here is to take a step back from the x-ray and look at the whole picture before deciding on whether or not to repair a fracture and then how to repair it. Consider species, age, state of health, the equipment at your disposal and your own experience. Don't treat the x-ray, treat the animal. There's one final point I'd like to make about fractures which you may come across, and that is the occurrence of pathological fractures. A pathological fracture is one where normal forces result in a weaker than normal bone fracturing. And there are 2 principal classes of pathological fractures that you'll come across. The older animal with an underlying bone tumour and the young growing animal with underlying nutritional secondary hyperparathyroidism. The first class of dogs will hopefully be obvious in x-ray, but if in doubt, x-ray the contralateral bone for comparison. Typical sites for this are near the knee and away from the elbow areas of the long bones, and osteosarcoma is usually the culprit. So we're talking about proximal humerus, distal radius, distal femur and proximal tibia. And the second class of dogs are puppies who have been fed an unbalanced, predominantly meat-fish diet during the active growing phase of their lives. These pups are often from 3 to 4 months when they present with fractures, and sometimes they will have multiple fractures. On x-ray, the bone cortices look thin and there is little difference sometimes between the density of the bone itself and the surrounding soft tissues. Neither of these cases should have a fracture repair attempted, as in neither case is the bone strong enough to hold the implants, nor is the bone healthy enough to heal. The bone tumour dog will require amputation to resolve its pain until the cancer catches up with it, and the nutritional dog will need put on a balanced diet immediately, possibly with calcium supplementation, although dietary correction is usually all that is necessary. The consequences of this individual's fracture will need to be addressed once a calcium balance is restored, but strict rest needs to be implemented to prevent further fractures occurring in the meantime. The x-ray at the top here is a case of nutritional secondary hyperparathyroidism, and you can appreciate there's a distinct lack of mineralization of the bones, the femur here, the vertebrae, sometimes appearing no denser than the soft tissues. Below is the classic appearance of an osteosarcoma, although in this case it is present in the distal tibia rather than the more usual proximal location in this bone.